Well, South Africa has one of the most impressive healthcare system on the continent, and that is why some others in other developed countries would also go to South Africa just for one thing, because it has a cheaper healthcare delivery system. But in all of this good, South Africa still, suffers from having a proper primary healthcare center or system, and that is why we have returned to the square to keep looking at how best to get Africa's primary healthcare system working. Welcome to the square. I'm Sulai, and on today's edition, we'll be talking pretty much on what is happening across the continent. It's a long, conversation we've been having with experts across the continent, and we have come to realize that primary healthcare is the foundation of the best health systems in the world. In Africa today, many citizens can't afford the cost of health, yet are struggling to cope with the cost of living. South Africa spends greatly on its health and encourages private companies to invest in the sector. More than half of its medical doctors work in the private sector and are compelled to travel abroad. Now, Nigeria, which like South Africa is a giant economy on the continent, spends lesser on its health, and about half of its health workforce seek greener pastures abroad. In both instances, the absence of a sound district or state health system is a foremost challenge, like in many African countries. Now, joining me today on the square is SIBONGILE TSHABALALA, who's the Chairperson, Treatment Action Campaign, Johannesburg, South Africa. Thank you for joining us. And of course, later on, Dr. EMMANUEL AGOGO will be joining us. He's Nigeria's country representative of Resolve to Save Lives, Abuja in Nigeria. Okay, I understand EMMANUEL is already with us. Thank you very much, gentlemen, for joining us on the program today. Very quickly, let's go to South Africa, where we started off talking about the healthcare system there. Now, what has been, let's start with you, EMMANUEL. What has been your discoveries in your various programs with communities? Does the government, seem to take primary healthcare seriously?
Thank you very much for the question. So primary health care as an idea, started with the Alma Ata Declaration in the 70s, 1978 to be precise. And the conversation then was that, globally there was a drive for countries to develop health systems that were appropriate for themselves, definitely targeting interventions that were available at the community level as an underlying mechanism for ensuring that universal coverage of was achieved. So that means that everybody can access healthcare where they need it. And what has happened over the years, obviously, is that there's been, despite this great interest and knowledge about primary healthcare, it has turned out that investment in health has not really, has not really been at the level. In fact, Nigeria led at the Abuja Declaration, where the discussion was that we should have 15 countries in Africa applying 15% of their budgets to health. No country in Africa, it's only, I think, Rwanda that more recently has come close to that. Nigeria has never reached that, that target.
Well, it's a shame because the conversation that we've been having with a lot of people, even Nigerians, hasn't actually shown any kind of seriousness as you highlighted. But let's come back to the universal health coverage. Shouldn't this, largely help to offset the burden of most countries in sponsoring primary health care? Do you think countries are making good use of this at all?
So again, maybe we'll take a step back to look at the way health systems are organized. So when we talk about this, the primary, secondary, tertiary healthcare systems, and sometimes we, use an example of perhaps the most stable primary healthcare system in the world, which is the United Kingdom where I was privileged to work for a few years, you have a well-established primary healthcare system that is funded by the federal government. And then you now have the secondary healthcare systems that is funded by local councils. And then the tertiary health system is funded by, smaller, regional groupings. Essentially, you provide help and care to most people at their point of need. And therefore, the system is built in such a way that if you have a problem, you're able to access it before it becomes a huge problem. But historically, in many developing countries, the investment has always been in big, large hospitals where we focus on investing in very expensive tertiary hospitals, so in specialist hospitals where the care is concentrated, and therefore you find that people go to a tertiary hospital to receive care that should be available at the primary healthcare system. Another mismatch that has happened over the years is the fact that the training of healthcare workers has always been that we've invested in training very high-level specialist skills without ensuring that we also train a broad base of health workers who can also provide simple healthcare, simple interventions for problems that people have at the community. The other challenge we've always had as well is globally is the problem of the Universal Square Law, where the people who need care the most, unfortunately, are most unable to access the care that they require. And therefore, there is a fundamental need to rethink how our health systems is structured, how is it funded, and how the priorities are directed. Previously, the primary healthcare system was under the management and control of the local government. I remember that the local government as a system is as a tier of government is one of the weakest tiers of government. And unfortunately, you have the weakest tier of government managing the most expansive and most important part of the health system, which is the most relevant and which is the closest to the community. And therefore, we need to rethink that structure. Fortunately, Nigeria passed the law establishing the National Primary Healthcare Development Agency, and subsequently also developing state primary healthcare development agencies. And there have been various initiatives to try and strengthen these organizations. Of course, we have seen in the context of COVID how the weakness and the challenge with having a functional healthcare system, especially at the primary healthcare level, has affected the ability to deliver care.
We'll come back to you, Dr. Agogo. Thank you for bringing two key issues. You talked about the structure. You also mentioned the funding, which we'll come back to. Very quickly, let's go to South Africa. I see SIBONGILE TSHABALALA with us. Thank you for your time, and thank you for joining us on The Square today. Quickly, the conversation hovers around primary health care. We already understand South Africa is doing well in terms of secondary and tertiary health, but the primary health care is our focus. Take us through, the process as it stands in South Africa. We understand, just like so many other African countries, the primary health care in South Africa is also in a bad shape.
It's very in a bad shape. I can safely say that in South Africa, the healthcare system, all of it, as much as there's a perception that on the secondary and the tertiary we are doing very well. As I'm talking to you now, the tertiary hospital, which is Charlotte Maxeke, is closed, and it's been closed for weeks. And we've been asking the government to open that hospital. What does that mean? It means patients with oncology, because that hospital caters for people who are having problems of oncology, are left stranded. Coming to the healthcare, primary healthcare, that is a disaster. You go to the facility, you don't get a medicine. You go to the facility, there is not enough staff. You go to the facility, the infrastructure is terrible. So the primary healthcare in South Africa is in shambles. The facilities are very small. It cannot even cater for a community, a small community of people in the facility. So what does that mean? It means people here in South Africa, as much as we are seen as the world-class country and we are a middle-class income country, but challenges on the ground are different from what it's been tabled, or how people think that we are living a better life, things are better. Things are very horrible on the ground. we are losing people day in, day out because of the crisis of the healthcare system that we are facing in South Africa.
Before I come back to Dr. EMMANUEL AGOGO, let me stay with you, Dr. Tshabalala, because listening to you would make many Africans ask the question of how good is public-private participation in the development of South Africa's primary healthcare. If there's something that the government perhaps hasn't been able to, soldier on alone, are there partnerships in place to help bring the primary healthcare centers back on, to working?
It's very minimum what the private private sector is supporting the public sector in South Africa. Very, very minimum. Only few places where you'll find the private sector coming in to assist the situation. Private sector in South Africa, they only think about their pocket. It's only about them. That is why, as activists in South Africa, we are worried if we are going to implement NHI policy or NHI in its current form, because it doesn't cater for us, people of South Africa or people on the ground. It only caters for those who can afford. So what I'm trying to say is that inequality in South Africa is still the problem. When we are poor, then we are suppressed more. When we are rich, that's when we are getting better services. You go to the next hospital next to the public hospital, the private hospital, you find that there are better services. But when you get injured next to the private hospital, you cannot be taken there when you don't have medical aid, or you cannot afford to pay that hospital. You'll be driven to 5 kilometers away from the hospital where you are living, the private hospital here. So there is no collaboration. The only thing that private sector in South Africa they think of, it's how they make profit out of poor people.
Well, Dr. EMMANUEL, I am quite sure you want to react to that, but very quickly, just today, in one of the dailies in Nigeria, we saw that a primary healthcare center in the heart of Lagos, specifically in the Ojodu area of Lagos, is also in a bad shape. It made headlines today. It would seem as if what Tshabalala is saying cuts across many African countries. Dr. AGOGO.
Well, like I said earlier, one of the things that has not really happened is the fact that our countries have not invested enough in the healthcare systems. And that gap is not only around the primary healthcare, it's all the way to the top. If you recall, at the beginning of the COVID-19 pandemic, many countries could not boast of ICUs, they could not boast of oxygen, which are things you see in tertiary hospitals. Not to talk of, the issues that you now have in the primary healthcare. So our organization actually looked at gaps during the COVID to say, well, at the primary healthcare facility, what was available? Were hand washing stations available? We looked at, what kind of support can be provided in terms of developing infection prevention and control interventions that can help prevent healthcare workers from being infected. My sister talked a little bit about, the private-public healthcare divide. The truth is that our countries need to invest a lot more into ensuring that people are covered with insurance, and that's only the way that you can actually provide more robust healthcare services to patients. And so the gap of funding is major. The gap of funding is significant. And like you said, even though there have been initiatives over time by government to invest more in primary healthcare centers, many of those investments have not resulted in better facilities. They have not resulted in having enough healthcare workers. They have not resulted in having good laboratory services at the primary healthcare level. It has not resulted in, in situations where people can access care, within a few miles of their homes. We know that many times people need to look for a vehicle, look for a bike or something to go, even when they are at death's door, or when they are in labor. And many lives have been lost needlessly, just because the healthcare system has not been built or funded effectively to deliver care, even at the primary healthcare level.
Well, that's why I'm excited that I have both of you here looking at the organizations you both represent. Now, let's talk about your organizations. I start with you, TSHABALALA. You are the chairperson Treatment Action Campaign in Johannesburg, South Africa. Looking at health and a couple of other things within the health sector, tell us what you and your team are doing to ensuring that truly people get better treatment and very quickly and affordable too.
What we are doing as Treatment Action Campaign, we are monitoring facilities, we are advocating for better healthcare services. So what we do, we go to facilities and look that people are getting the services that they are supposed to get. If they are not getting that, we engage to TPRs in order for them to deliver services. If we are not getting joy, then we take it to the streets and we make sure that we push it. So a Treatment Action Campaign is known of one of the organizations that is not afraid to take our government to court. As I'm talking to you, we are thinking of taking our government to court because of the healthcare system that is happening, because of what I just spoke about earlier on in Charlotte Maxeke, to say Charlotte Maxeke is when it's closed, how many people are dying of cancer while they were supposed to get assistance in Charlotte Maxeke. So briefly, that is what we are doing. We are also monitoring policies to say the policies that are there in the country are implemented as they are supposed to, because you find out that we have good plans, we have good policies at the national level, but when you go to the ground, those policies are not implemented. So one of our roles is to also monitor the policies and also engage the government to say, how best can you implement these policies? So we are not only advocating, but also on other times, we are advocating for better healthcare services.
And TSHABALALA, how has following up on some of these key, issues you raised been? When you push for follow-up to the government and to the parliament, have you recorded some success so far?
If it's our successes, then it will take the whole day. However, we in South Africa as today, we have 4 million plus people who are on ARVs, and that is our Treatment Action Campaign. We as Treatment Action Campaign, we managed to save babies, and we have managed to also advocate for prisoners, inmates, to access treatment. We have managed to force government to people for TB everywhere where they go, especially in health facilities. We have managed to force the government or to advocate for government to take up issues of TB. As I'm talking to you, we are in engagement with the government to say TB is the #1 killer in Africa, and why African countries are not taking up the issues of TB. And how about South Africa be the one of the countries that lead by example by declaring TB as an emergency? We also involved in fix the patent laws in South Africa and internationally. So as I'm talking to you, when we saw the Joe Biden signing the TRIPS waiver and agreeing that we need the TRIPS waiver, it was one of our work with other partners that we are working on. So there are a lot of successes that I can count of, starting from 2000 till today. We are continuing to have more successes because more people are accessing facilities, and we are regarded as one of the organizations that is holding our government accountable in South Africa.
And Dr. EMMANUEL AGOGO, quickly here, just recently I had conversations with experts like yourself in Kenya and of course in Zimbabwe, and some of the key things raised are number one, looking at people in rural areas, also how much of a neglect these people suffer. Your organization Resolve to Save Lives. Tell us how it's been like in its resolve to helping that, to saving lives.
Resolve to Save Lives is an initiative of Vital Strategies, and our role has been at working at 2 levels, working on preventing cardiovascular disease, as well as supporting treatment of cardiovascular diseases. And our focus with cardiovascular disease has been looking at how do we work at the primary healthcare level to introduce algorithm-based treatment for hypertension. And this has gone very well. We work with the Ministry of Health, we work with the Federal Ministry of Health, we work closely with MPHCDA, the state's primary healthcare development agencies. And basically what's happening at these levels really is a situation where we are looking at how can you bring treatment of hypertension much more closely to the community, so that at the primary healthcare level, you can be treated for hypertension, which is one of the biggest killers. Cardiovascular disease, as we know, is one of the biggest killers in Africa and Nigeria in particular. So that's one intervention. The other intervention is around preventing epidemics, where we work with the Nigeria Center for Disease Control around surveillance and preparedness for outbreaks. One of the things we also are beginning to realize is that you cannot even prevent any outbreak, whether it be COVID, whether it be cholera, whether it be Lassa fever, without engaging effectively at the primary healthcare level, because every epidemic starts with a case. Every pandemic starts with a case. And that case usually will start at the primary healthcare level, at the community level. And so if you don't have systems in place to rapidly identify issues, cases that are abnormal, report them through the well-established channels, then you will be prone to having recurrent outbreaks. And remember that Nigeria has had recurrent outbreaks every year we have outbreaks of meningitis, we have recurrent outbreaks of measles, we have cholera every time. And while we know that many of these interventions to correct these may not necessarily be only from the, the health system, while we know that that's not the only intervention, that the social side is also important, having a strong primary healthcare system is essential to respond effectively. And that's why that is the bedrock of any intervention that Resolve is working on now. And that's why, as a government who is interested in taking care of our citizens, that investing in the primary healthcare system is very essential. That investment means that beyond having fancy buildings, you need to have it staffed by the right kind of healthcare workers. You need to make sure that medication, drugs are available at those facilities. You need to make sure that referral systems are in place, so that if you are unwell, you will not be kept there beyond the capacities of the people who are there. So resources are there. Then as an ambulance, there's a linkage where you can refer somebody who is.
Well, I think looks like we lost that connection to Dr. EMMANUEL AGOGO. Now, let's hope that we get that. Before we go back to South Africa, these are some of the key issues we have identified listening to Dr. EMMANUEL AGOGO, who is the Nigeria country representative of Resolve to Save Lives. And it's not any different from the conversation we've had with all the health experts. It's good to see that you're back, TSHABALALA. Now, let's go back talking about this very important and disturbing, scenario or issue of health. South Africa's primary healthcare centers are 5 kilometers away from 90% of the population. And I think that's impressive, but are these enough in a country as big and developed like South Africa?
To have a facility 5 kilometers away from where we are living or from where people are, it's one of the good things. But if that facility doesn't have all the equipment, it doesn't cater for people, then it's useless. So that is the situation we are finding ourselves in. You find people leaving the facility nearby because there are no services in that facility and go to the better one. People are prepared to pay, although they don't have money, although we know that COVID has affected us, we've lost employment, but people are prepared to walk 10 kilometers to get better services. So that is the situation that we are faced. So it's a good thing that health facilities are nearby, are 5 kilometers away from people, and people can just walk to the facility. But it's also frustrating when you have to go to the facility that is just next door to you, but you have to wake up at 4 o'clock in the morning and queue outside, and you leave the facility at 4 p.m. without even medication, without being seen, and without good services, where you have to face the attitude of a nurse, and you have to start to deal with the security who had the attitude, and you go to administrator who has the attitude, and you go to the nurse who has the attitude. At the end of the day, you don't even get your medication. You can imagine how frustrating is that. So to have this facility, it's one good thing, but are useless for us because they are not catering for us. So people prefer to go to hospital and secondary healthcare and tertiary healthcare, because at the ground, at the primary services, we are not getting services that we are supposed to get.
This is really sad because truly a good, as you identified, a good policy in place, but it makes nonsense if that facility is ill-equipped. Now, what is the government or the parliament doing to ensure that these facilities have the necessary first experts to man them, and secondly, the necessary, equipment and tools and drugs for the people? Tshabalala.
Honestly, less that is happening. There is no political will. You only hear people saying the good things, as I'm always saying, that our politicians and our duty bearers are very good at saying all the right things, but go on the ground, there's no such. We are getting nothing at all. I can say we are not happy about what is happening. We are losing people every day because on the ground, we are not getting anything. The only thing that politicians and the parliament that they care about, it's their pockets. We are hearing politicians stealing money, stealing from the public place every now and again. As I'm talking to you now, the Minister of Health in South Africa is suspended because he is implicated in a corruption of 150 million. That money was meant for COVID, and they used that money for communications. Communications for what? That will take 150 million. If they took that money to the ground, to the people, that money could have made so much difference on the ground. As I'm talking to you, there are no beds in hospitals yet in Gauteng. People are dying every day. I'm talking to you, I just lost my aunt due to the poor service of South Africa. So the services here in South Africa are not good. And the politicians are sitting there in parliament and saying all the right things, but not doing the right thing on the ground. So for us, that is useless. We are tired of listening to them saying all the right things, but on the ground not doing anything that is right.
Well, our condolences, Tshabalala, on the loss of your aunt, and we hope that this conversation ultimately will help Africa, revamp its primary healthcare system. Dr. EMMANUEL AGOGO, good to have you back again. Before we go on the break, I want you to react to some of the few things you heard Tshabalala. She said, first, they have a policy in place in South Africa that puts health facilities not more than 5 kilometers where you live. But that policy hasn't actually worked for a lot of people in South Africa because, according to her, what's the use of a facility that is ill-equipped?
Yes, even in Nigeria, the plan has always been that you have one primary healthcare center per ward. And a ward actually caters to about 10,000 people on average. So that in Nigeria, what we have is actually quite, insufficient. And there isn't any evidence that each of those primary healthcare centers works effectively, that they have the staff required, or that they have all the equipment and things needed. So that is a real challenge that we have in Nigeria.
Well, we'll go on a break. When we come back, we'll talk more about some of the key things as Africans we must do to bring back the primary healthcare system and, of course, the entire health sector working. Join us again. It's a home run here on Village Square Africa on News Central Television, and our focus in the last days, is on Africa's primary health care, and it is a sector that must develop beyond just first-hand therapy. In a fast-growing system where mental health challenges are also foremost, it's highly important that primary health care centers are total in approach. Africa's health system has great potential, but it will take political will, as TSHABALALA in South Africa, said earlier before we went on the break, and also passion to place it where it belongs. And that's why more discussions and actions are needed. The Alma Mater Declaration on Primary Health happened more than 4 decades ago, and it's high time African nations saw the health of the people as utmost priority and one key to having better nations. And well, the conversation today is something that I've been having with SIBONGILE TSHABALALA, who's the chairperson, Treatment Action Campaign in Johannesburg, South Africa, and Dr. EMMANUEL AGOGO, Nigeria country representative of Resolve to Save Lives, Abuja, Nigeria. And quickly here, TSHABALALA, we're trying to look at some of these things happening across most African countries. And listening to you, one thing is, there's a sore point here, and that is primary healthcare centers are nurse-based and doctor-supported. But listening to you, I've been able to get one thing, which is you don't have these experts manning some of these places. Does this also, resonate with, some of the campaigns by your group to the South African government to ensuring that we have qualified nurses, qualified doctors, in these centers?
Yes, that is one of our campaigns. And earlier on, I spoke about shortages of staff in facilities. When you have all the required staff in the facility or human resource, then it will be easy for healthcare workers to provide better services because they'll manage to work in a possible way or in a healthy environment. Like for instance, what we are seeing now on the ground, you find out one nurse has to see about 150 patients a day. And as much as we are complaining about attitude, how could you expect somebody not to have a bad attitude or negative attitude towards people? Because at the end of the day, this person we are talking about is a human being. It's not a robot. And that person has to listen to all these people, have to come up with possible solution with all these people. And you spoke about a doctor and a qualified doctor, a qualified nurse. That's not what we are seeing on the ground. In South Africa, you find primary healthcare services that usually they don't have doctors. And if they do have doctors, it will be one doctor who will come maybe once a week or twice a week. So what does that mean? It means that that day that the doctor came, everyone will have to be booked to come to the doctor, which is still a problem. So as Africans, we need to start planning better instead of planning better and doing something wrong or something that is not assisting people on the ground. What we need to do is to start planning and implement better. What we are talking about, let us not just be good in speaking or in writing policies and in saying all the right things. Let's say the right things and do the right things. Let's have good policies and good implementation. That's what all we need. So if we don't have that, let's hire human resource. Because if you have less staff and you expect to get quality of work, that is not going to happen. People are working on the ground, and we expect the best from them, which is not fair. When anything goes wrong in the facility, we blame a healthcare worker, but we don't blame those who are in power, who are not providing equipment for these workers to be able to work.
Let me bring in Dr. Emmanuel Agogo to help us here. Listening to Tshabalala, she said something about burnout syndrome, which is very key here. Someone who's there with a whole lot because it's just her or him alone. And she's also said something about the experts to man these places. Quickly here, help us, Dr. Agogo. Some experts have said locals can be trained to be first responders to local health emergencies. How can this help if you're also on the same page with those who are canvassing for this?
I mean, I must say that, you know, just like Tshabalala said, you know, health services are not delivered by machines, they're delivered by human beings. So, and one of the biggest gaps that we have is the human resource crisis that we have in the healthcare sector in Nigeria and across Africa as well. You know, when we analyze and we see the number, the ratio of doctors to nurses, to patients in Nigeria, it's way below the recommended numbers by the WHO. The numbers of nurses compared to patients as well, it's definitely way, way below the numbers recommended by the WHO. And so we find that the way the system has been developed, we do now have at the primary healthcare level, you know, community health extension workers, so CHUs and JCHUs and junior community healthcare extension workers and midwives who are now the frontline workers at the primary healthcare level. So in Nigeria, there are also the primary healthcare centers are also categorized based on the staffing, so the tier 1, tier 2, tier 3, depending on how many staff are there, what quality of staff are there, so in terms of training, not in terms of ability to work, because a lot of these staff, even though they may not be have the very high level training, are pushed and have to deliver services sometimes far above their competencies and sometimes far above what legally they are allowed to do. And that's why certain interventions that are being developed called the tax shifting, tax sharing policies are ways of ensuring that, you know, staff who are, you know, have less training, who are in cadre-wise are lower, you know, lower cadre in terms of seniority compared with doctors and nurses, that some certain tasks can be shared or shifted to people on those to those people who have that training, and provide them the training to be able to provide those services safely and to understand their limitations and know when to refer. So the human resource issue is complex. And then there's another, there are two more issues to talk about. There's one in terms of there's an inverse scarcity where many doctors, many nurses, many CHUs are trained, many lab scientists are trained, and they're out there without jobs. And yet within the public health system, there are not enough people working. So that's also that contradiction. And the last real issue is the fact that, you know, everywhere in the world, people want better lives for their families. And therefore, you know, recruiting and retaining healthcare workers who work in rural areas and in underserved communities and in communities where there is crisis, where the need is greatest, is so difficult. And therefore, you have this, you know, this complication where people who need the care are not able to access the care because the services are not available close to them. And what my sister said in South Africa is similar. I mean, I did a nationwide assessment of the South African health system as part of the joint external evaluation a few years ago. And they do have some very good, you know, primary healthcare centers. But like she said, you know, it is always the case that the people who need the care the most, people who are economically, who have economically challenged, cannot access the care easily. And that's the importance, that is why it's so important for the government to invest in health insurance systems so that people can access care and that we all can put in the pot and be our brother's keepers again. So health insurance as a means of scaling up health services is really critical.
We'll come back to you, Emmanuel. I'll come back to Tshabalala. Listening to both of you, there's something about the continent. And the continent, Africa, knows that it takes a village to raise a doctor. Sometimes communities all come together, pool resources together to get someone, just an individual, you know, trained as an expert, as a nurse, as a doctor. Are there things in South Africa? I'll come back to asking AGOGO about Nigeria. More like an incentive that the government gives, to health workers, especially those who work in rural communities, that will make them stay. It's akin to a journalist who's asked to go to a war zone. He or she has some special, allowance, the risk involved. Is your group in South Africa also pushing, if there is none, for doctors? Because there must be something that will, encourage these experts to stay in those communities and care for our people in the villages.
Yes, there is a bit of incentive, although it's not enough because we are unable to keep them, most of them, in rural areas. Hence, we as TAC, we are working with other organizations. One of the organizations that we are working with, it's a rural health advocacy project, which is looking at the healthcare in rural areas, how doctors are supported there, the finances and all those things. So yes, there is a bit of incentive, but because of cost of living in South Africa, which is very high, and people are struggling, people opt to go to urban areas than in rural areas. And at some point, those incentives that they are supposed to get them, at sometimes they don't get them. So which makes them to be demoralized and feel like, no, they are not much appreciated as they are supposed to, which it doesn't keep them most of the time. And also, we need to remember that as much as we are training doctors and nurses in Africa, also European countries are taking these people and are paying them much better. So as African countries, we need to find a way of how are we sustaining our doctors and nurses so that we don't suffer like this. But it is difficult to keep them because we train them, but at the end of the day, we don't give them jobs because there are a lot of posts that are frozen in rural and in urban areas in South Africa, which those posts supposed to be filled, but we are told that there is no money to pay them for those posts to be filled. But there is money for corruption, which is so saddening.
Well, Dr. AGOGO, I'm almost certain that I don't know your village or your community, but I'm almost certain you're not too happy when you go back home as a medical professional, seeing the state of health, facility or structure in your community. Now, listening to TSHABALALA, she's also raised a very important point. We have very few people like yourself that have resolved to stay back on the continent to helping people stay alive. Some of your colleagues have actually left. What are those things you think Africa is missing that Africa should put on the table to see that less and less of its experts in the health sector stay back on the continent?
So I have a conflict of interest there. So I moved to the UK and spent about 11 years or so training and working as a primary healthcare physician. So, this is a topic that is really close to my heart. But I returned to Nigeria about 7 years ago, just because of, realization that, we all have a part to play. And, my previous roles at the NACA and at the NCDC were really around building systems. So understanding that, our systems are as good as what we, are as good as they are, whether at the primary, at the village or at the city. And also the fact that, wherever we are, we have people, part of our people in my village in Benue who are dying needlessly just because they can't access basic care. And so for me, it's a personal passion and a personal vision to say, look, how do we build systems that make sure that, lives are not heedlessly lost, that women don't die in labor, that people can monitor a woman and know when she's at risk and refer her on, that a child with malaria, that someone can quickly identify a child with malaria and treat appropriately, that people are not exposed to fake drugs and harmful sometimes traditional treatment and harmful quackery that happens, that lives are saved. So that's really, the driver for us to say. And I think if we have that vision, we will realize that you can't stop, highly trained professionals from being mobile. But we are not even harnessing our biggest resource in Africa, which is our young people. We're not training enough doctors. We're not training enough nurses. We're not training enough lab assistants. I believe we can invest in this, and Africa can actually be the powerhouse exporting doctors and nurses to the rest of the world while we still have enough. Because no country, as it is, has enough doctors and nurses. And so if you have good quality, hardworking people, which Africans are, they will always find a place outside in other countries in the West. And so for me, it has to be a deliberate action to say, look, we need to build our human resources, not only with the idea in mind that there will be attrition, there will be deaths, there will be people moving. So how do we invest in that? To even add something to that, I was involved as a lecturer at the University of Birmingham, where we taught physician assistants. So they developed new cadres of healthcare workers who were interim, who were somewhere between doctors and nurses as physician extenders. You have something like that in Kenya and in other countries. So we need to be innovative and look at new healthcare, innovative models of healthcare delivery. We need to look at, IT. How can we, streamline attendances? How can we provide more healthcare, health promotion information to people so that they can also do more self-care? We also need to think about, the investments in actual functional centers. So how can you have a primary health care center where water does not run? What kind of care can be provided in that kind of center? How can you have healthcare workers whose salaries have not been paid for 3 months, 6 months? I was chuckling to myself when my sister was talking about just the volume of staff that patients that doctors and nurses and CHUs sometimes have to deal with, and that was my experience as well. But imagine doing that without a salary for the last 6 months, and how excited you might be, treating patients. So there are multiple issues here, but and I think that we need to almost declare a state of emergency in the healthcare system in Africa post-COVID, and have a continent-wide approach to saying enough is enough. If fortunately, for various reasons, some known, some unknown, COVID did not have the same impact in Africa. But if it happened the way it happened in India and Africa, we could have, we would have been in a completely bad shape. And so I think we should really get to that stage where we're saying enough is enough. How can we have a Marshall Plan, a concerted plan where where corruption no longer, we do not allow the attrition of funding in the healthcare system, that the monies meant for beds are gone for beds. The monies meant for people's salaries goes there. That the healthcare system, right, especially at the primary healthcare level, is working for the majority of Nigerians and Africans as a whole.
Let's start winding down. I'll go to Tshabalala, but I'll come back to you to close on telling us more on the health extenders you talked about, EMMANUEL. Tshabalala, listening to EMMANUEL, he's sounding almost like you now, talking about Africa has potential, but it looks like the money and the resources are being diverted to something else. How can Africa's primary health care be improved, on, and keeping in mind some of those key things you raised? You also used the word, you were very categorical, money, corruption. How can Africa, fight corruption in the health sector?
We need a political will as Africans. We need leaders that are committed into providing better health for Africans. We need to have discussions, honest discussions as Africans, to say where we are and where we are going as as Africans. Where are we taking ourselves? If we are known as a continent that is corrupt, if we are known as a continent that cannot deliver, not because we are incapable, as I said earlier on. We have capacity, we can do it. We are very genius in Africa. I believe that Africans can do much better, but we need political will. We need leaders who are committed in providing better health or better services to people and in improving people's lives at the end of the day, which is more important. As soon as we start to have that discussion and also implement it correctly, you know, primary healthcare system is very important because that's where people are. And if we can master it, I'm telling you, all what we are seeing in Africa will be less, like the challenges that we have in Africa will have less challenges. The xenophobic attacks that we are having against each other as Africans will be better because that's where we will show how as Africans we can do it and how can we work together as Africans in order to make our people lives better. So all we need is commitment. All we need is political will from all African leaders so that we can have a better Africa.
Well, as we look towards a commitment and focus and political will from African leaders, perhaps, Emmanuel, you can help us by, giving us a sense of what the health extenders are, because it's something quite new to a lot of people. If you can, in a minute, expatiate more on what that meant for the health sector.
So I think it's really under the idea of tax shifting, tax sharing. So a lot of the basic healthcare interventions can be done by lay healthcare workers. So the idea is that if we cannot have enough doctors and nurses, we need to look at other alternatives of people who we can build capacity or train to also provide services. So these are like physician assistants that you have in the USA. In Nigeria, we already have community healthcare extension workers. We have in the UK, you have people like nurse practitioners. So it's really rethinking the health workforce and making it more dynamic. That's one hand. But it's not only about recruiting people, it's also about retention. And retention starts with, payment of salaries, making sure that people are not, it's not about even the basic remuneration they get, are they being paid? Are they getting good hazard allowance? Recently, the hazard allowance for healthcare workers in Nigeria was 5,000 naira. So that is pitiful. So we need to look at ways of training, retaining and retention interventions, so that you can hold them accountable. It's when you have made sure as a government, you've done your bit, that you can hold healthcare workers accountable. There's also the need, like I've been saying again, for health insurance, because there is no way, no government will say they have enough money to fund health. So how can we ensure that the health insurance system is available, is working, and that the funding is in place to make sure that the hospitals, the facilities, the primary healthcare centers are working? Because healthcare workers cannot work without the requirements. They need the BP machine, they need all the equipment. So there are several facets, and we need to attack all these ideas at the same time.
Well, no doubt primary healthcare is the soul of a viable health system, and one without it is never good enough. And at this point in time, we should be asking ourselves the question, is Africa's health system good enough? That's the question we all need to answer. Many thanks for being such nice company, SIBONGILE, TSHABALALA, and Dr. Emmanuel AGOGO. Thank you for your time. And again, to our viewers across the continent, many thanks for watching. See you again tomorrow.